Hello, my name is Arman Memarzadeh and I'm an orthopaedic registrar on the Cambridge rotation. We will be discussing the PROFHER trial, proximal humeral fractures. Equipoise was first used by Benjamin Friedman in 1987, published in the New England Journal of Medicine. It describes genuine equilibrium within the medical community regarding the treatment used for a particular condition, such as whether to treat proximal humeral fractures operatively or non-operatively. The PROFHER trial was performed recently to assess the efficacy of surgical versus non-operative management of humeral fractures. If you would like to test your knowledge, we have devised a quiz which you can perform online before and after watching this video to see whether you have improved. Simply go to www.socrative.com, entering the room name that you can see on the slide. So the PROFHER trial was published in the Journal of American Medical Association in 2015. This is a journal which has a very high impact factor of 37.7. The first author is Professor Arman Memarzadeh within the UK. The aim of the trial was whether non-operative management of proximal humeral fractures results in better outcomes compared with operative intervention. The anatomy of the proximal humerus is demonstrated here. The trial was particularly interested in looking at proximal humeral fractures involving the surgical neck. The definition of a part, as defined by NEAR, is more than 1 centimetre of displacement of a part or 45 degrees of angulation. Moving on to the methods, this was a pragmatic superiority and multi-centre trial with a catchment of 3 years between September 2008 and April 2011. This was 1-to-1 randomisation and 2-year follow-up was utilised with outcome measures being recorded at 6, 12 and 24 months. The power calculations resulted in 125 patients in each arm and full ethical approval was maintained. The inclusion criteria were adults presenting within 3 weeks of injury with displaced fractures. There was quite a long list of exclusions, including dislocations, open fractures, patients with insufficient mental capacity, and comorbidities precluding anaesthesia, and a clear indication for surgery. It's important to highlight this, and that those non-resident in the area were also excluded. There were 2 arms to the treatment, an operative and a non-operative treatment. In the operative group, the treatment was based on the surgeon's preference for that particular fracture. And this could have been plate, hemiarthroplasty, intramedullary nail, or other. In these cases, these were screws. In the non-operative group, there was a sling for as long as the patient required it, which was followed by physiotherapy. Looking at the initial results, you can see that 1,250 patients were assessed for eligibility and 250 were randomised. There was an 80% exclusion rate in this initial phase, and it's important to highlight this. The authors include a list of the reasons why these patients were excluded. You can see that 687 patients did not meet the inclusion criteria, but despite this, 313 patients refused to participate. We'll come back to this later. Looking at the demographics, the mean age was 66 and most of the patients were female, which is not surprising given the population we're looking at. Overall, there were over 100 patients in each arm, which met the power calculations, and 94% of the operations were performed either by or under the direct supervision of a consultant. Looking at the results breakdown of the patients, different fractures which were included, a number of different fracture configurations. However, most of the fractures were either 2-part fractures involving the surgical neck or 3-part fracture involving a surgical neck and the greater tuberosity. And you can see this composed over 80% of the study population. Again, a very important point to highlight. In terms of treatment, most of the patients received plate and screws. That's over 80% of the population, followed by hemiarthroplasty or a nail and screws. It's important to highlight that the reverse total shoulder replacement was not utilised at all in this population. And one could argue this may be a treatment option for some. In the non-operative group, most patients received a broad arm sling, some with a collar and cuff, and a very small minority with a hanging cast. The results trended towards better scores at 6 months in the operative group. However, this was not statistically significant in any of the subgroup analyses which were performed in the study. It is important to say that the plateau reached a very similar level at 12 and the 24-month period. This, again, a very similar finding in all of the subgroup analyses. Finally, there were slightly more complications in the operative group. However, this again was not statistically significant. Moving on to the discussion section of the paper, it is clearly mentioned that there is no statistically significant difference between the operative and the non-operative groups over the 2 years. 6 points were discussed in depth. However, there was unfortunately no mention of a large percentage of excluded patients. We noticed that this was 80%. To critique the paper, it is important to highlight the positive aspects. This is a very valid question to ask, and a solid statistical basis was utilised to perform the study. And it is also well coordinated, involving a number of highly regarded centres in the UK. Similar baseline demographics were also noted, and a very good follow-up rate was seen. To critique this further, 250 participants were recruited from a potential 1,250, only 20%. The breakdown of the types of fractures included was not part of the body of the article. This was an online appendix which had to be looked through, but it did show that over 80% of the fractures were either two-part or involving the greater tuberosity. This is not mentioned in the discussion section of the part paper. Similarly, there is no consideration for other types of arthroplasty, including a reverse total shoulder replacement. So is this relevant to our current practice? Well, it is a well-designed randomized controlled trial with a 24-month follow-up. And it is certainly a valid outcome that we can see, valid result, for a two-part or a three-part fracture involving the greater tuberosity. However, I would practice caution when extrapolating this to four-part, lesser tuberosity, isolated greater tuberosity, head-splitting fractures or dislocations. This is not a valid extrapolation.